When a nursing home resident needs transfer to the hospital, the nurse's job is to move quickly, think clearly, and follow the correct chain of care. This process is not just transportation, it is a clinical handoff that begins the moment the resident shows an acute change in condition. Think of the transfer as a relay race. If the first runner drops the baton, everyone after that is working with incomplete information. Your role is to stabilize the resident, recognize urgency, communicate clearly, and send the right documents so the next team can act safely. Always work within four boundaries: facility policy, provider orders, the resident's advance directives, and your scope of practice. Those four guide rails protect both the resident and the nurse. For example, a resident with sudden chest pain may need immediate oxygen, assessment, EMS activation, and rapid communication to the provider. At the same time, you must verify whether the resident is full code or has a DNR or pulsed form. A common nursing error is getting pulled into paperwork too early. In a true emergency, treatment and calling 911 come first. Documentation and notifications still matter, but they should support care, not delay it. Throughout the process, maintain dignity, privacy, and clear communication with the resident and family when possible. The safest transfer is organized, timely, and centered on what the resident needs right now. An immediate focused assessment is the first clinical step when a resident develops an acute change. Focused means you do not perform an unrelated head-to-toe exam first. Instead, you prioritize the body systems most likely involved. Start with airway, breathing, and circulation, because these determine whether the resident is stable enough for anything else. If the airway is obstructed, respirations are labored, or perfusion is poor, those findings take priority over every other task. Next, quickly assess level of consciousness and mental status. Is the resident alert, more confused than usual, difficult to arouse? Changes in cognition can be the earliest clue of infection, stroke, hypoxia, or sepsis in older adults. Then obtain full vital signs: temperature, pulse, respirations, blood pressure, oxygen saturation, and pain. These numbers give you objective data and create a baseline for trending. If symptoms suggest glucose problems, such as diaphoresis, altered behavior, weakness, or decreased responsiveness, check a blood glucose right away. Your focused exam should match the complaint. For possible stroke, assess facial droop, arm weakness, speech changes, pupils, and last known well time. For respiratory distress, listen to lung sounds and observe work of breathing. For abdominal pain, inspect and palpate as appropriate, noting distension or tenderness. Nursing implication: gather findings fast, but do not rush so much that you miss critical clues. Good assessment drives the right transport decision, the right report, and the right treatment. In long-term care, baseline matters just as much as the current finding. A blood pressure of 160 may be acceptable for one resident, but alarming for another whose usual pressure is 150/80. Mild confusion may be chronic in one resident, while in another it is a red flag for infection, stroke, or hypoxia. That is why nurses must compare the current condition with the resident's normal mental status, mobility, speech, intake, continence, and vital sign patterns. Think of baseline as the resident's personal normal, not the textbook normal. A resident who normally walks independently but now cannot stand has a major change, even if vital signs seem only mildly abnormal. A resident with dementia who is suddenly less responsive than usual needs urgent attention, not dismissal as confused. This comparison helps determine whether the condition is stable, worsening, or immediately life-threatening. Clinical urgency comes from both severity and change from baseline. Sudden one-sided weakness, new unresponsiveness, severe respiratory distress, or chest pain are obvious emergencies. But a more subtle decline, like poor intake, lethargy, and a low-grade fever in an older adult, may also represent sepsis or dehydration and still require hospital evaluation. For nursing practice, document what is different and specific. Instead of writing not acting right, write usually alert and conversant, now drowsy, minimally verbal, and unable to follow commands. That wording communicates urgency better to providers, EMS, and the emergency department, and it supports timely decision making. Once you recognize an emergency, begin immediate interventions within your scope and facility protocol. Do not wait for paperwork or a callback if the resident is unstable. This is where nursing action can prevent further deterioration. For example, placing a resident upright can ease work of breathing, while lying a syncopal resident flat may improve perfusion. Good positioning is simple but powerful. Administer oxygen if it is ordered or permitted by standing emergency protocol. Oxygen can buy time in hypoxic residents while EMS is en route. If the resident has altered mental status, diaphoresis, or a history of diabetes, check a blood glucose quickly. A treatable glucose emergency can mimic stroke or sepsis. If bleeding is present, apply direct pressure and continue monitoring for shock. If the resident has no pulse or is not breathing and the code status supports resuscitation, initiate CPR immediately. Another important action is keeping the resident NPO when aspiration, surgery, or decreased consciousness is a concern. Students sometimes forget that even a sip of water can create risk in someone with dysphagia or a possible stroke. Stay with the resident whenever possible. Reassess breathing, pulse, oxygen saturation, level of consciousness, and pain frequently. The key teaching point is this: emergency interventions are not separate from transfer preparation. They happen at the same time. Nursing priorities are stabilize, observe, reassess, and communicate. Immediate bedside care can dramatically change the resident's condition before EMS even arrives. Confirming code status and advance directives is essential because it guides what treatments are appropriate during deterioration and transfer. Nurses must know whether the resident is full code, DNR, DNI, or has additional treatment preferences documented in a PULST or MULST. These forms are not just paperwork. They are the resident's voice when the resident cannot speak for themselves. For example, a resident may want hospitalization for treatable conditions, but decline intubation. Another may prefer comfort-focused treatment only. If staff assume rather than verify, the team may provide unwanted interventions or fail to provide needed ones. That is both a clinical and ethical problem. Always locate the current document, confirm it is the most recent version, and make sure the information matches what is communicated to EMS and the hospital. Also, identify who is authorized to make decisions if the resident lacks capacity. This may be a healthcare power of attorney, legal guardian, or designated healthcare agent. Knowing this early helps avoid confusion when urgent decisions are needed. A practical nursing point: send the original or a clear, legible copy of the code status or treatment limitation document with the resident according to policy. If EMS arrives and no one can produce the form, they may have to proceed based on default emergency protocols. So, verification is time-sensitive. In short, confirming code status protects resident autonomy, guides emergency response, and ensures the receiving team understands the limits and goals of treatment. Some conditions require immediate EMS activation with no delay. Severe respiratory distress, chest pain suggestive of a heart attack, signs of stroke, unresponsiveness, uncontrolled bleeding, major injury, prolonged or repeated seizures, suspected sepsis, and severe allergic reactions are classic examples. The guiding question is simple: can this resident be managed safely in the facility right now? If the answer is no, call 911. Students sometimes hesitate because they want to notify the provider first. In a true emergency, that delay can be dangerous. Calling 911 does not replace provider notification. It simply comes first when the situation is life-threatening. For a resident with facial droop and new aphasia, every minute matters because stroke treatment is time-sensitive. For a resident with oxygen saturation in the 80s and increasing work of breathing, EMS activation should not wait for lengthy discussion. When speaking to the dispatcher, be concise and specific. Provide the facility name and exact address first so help can be sent even if the call is interrupted. Then, report the resident's age, sex, presenting problem, vital signs, level of consciousness, code status, and any immediate interventions already provided, such as oxygen, bleeding control, or CPR. This helps EMS prepare equipment and response level before arrival. From a nursing perspective, stay organized during the call. Have the chart or key facts in front of you if possible. The better your information, the smoother the handoff from facility to EMS, and the faster definitive care can begin. Not every hospital transfer is a 911 emergency. Some residents are stable but still require evaluation, such as for worsening anemia, non-urgent imaging, or a change in condition that needs hospital workup without immediate life threat. In these situations, use the provider's order and arrange the appropriate level of transportation. Choosing the right transport is a safety decision. A wheelchair van may be appropriate for a resident who can sit upright, has stable vital signs, and does not need clinical monitoring. Stretcher transport may be needed for residents who cannot tolerate sitting or who require full body support. Ambulance transport may still be required even if the situation is not 911 level, especially if the resident needs oxygen, frequent assessment, or has significant mobility or medical complexity. Before confirming non-emergency transport, reassess stability. A resident who was stable 30 minutes ago may now be hypotensive, more confused, or short of breath. If the condition worsens, escalate to emergency transport rather than continuing with the original plan. This is why nursing reassessment remains essential even after the initial decision is made. Also, think through logistics. Destination hospital, pickup time, anticipated needs during transport, and any communication barriers such as hearing loss or language differences. The nursing implication is that non-emergency does not mean low priority. Stable transfers still require thoughtful planning, current assessment, and correct transport matching to prevent deterioration during the trip and to support a smooth arrival at the hospital. Provider notification should be clear, efficient, and clinically meaningful. SBAR is the best structure because it prevents rambling and helps the provider quickly understand the situation. Think of SPAR as a map. Situation tells where you are now, background explains how you got there, assessment describes what you found, and recommendation states what action is needed. For example, situation: Mr. Smith developed sudden shortness of breath and chest pain at 2:15 p.m. Background: he has CHF, COPD, and hypertension and is full code. Assessment: BP 168/92, pulse 116, respirations 30, SpO2 84% on room air and 92% with oxygen, pale and diaphoretic. Recommendation: EMS has been activated and I recommend emergency department evaluation. That report is concise, organized, and actionable. If the resident is unstable, do not delay EMS while trying to reach the provider. Call 911 first, then notify the provider as soon as possible. In non-emergency situations, the provider's order may guide whether the resident is monitored in the facility, sent to the emergency department, or scheduled for another evaluation. Documentation of provider communication is part of safe practice. Record the exact time called, the provider's name, what information you reported, any orders received, and whether you spoke directly or left a message. This creates a legal and clinical record of the decision-making process. For nurses, the skill is not only collecting data, but packaging it in a way that prompts timely and appropriate medical response. Notifying the responsible party is an important part of resident-centered care and regulatory compliance. Depending on the resident's situation, this may be the legal representative, healthcare power of attorney, guardian, healthcare agent, or designated family contact. The purpose is to keep the appropriate person informed, not to ask permission for life-saving action in an emergency when immediate care is required. When you make contact, explain the resident's change in condition in plain, direct language. For example, your mother developed sudden weakness and slurred speech, and we are sending her to the emergency department for evaluation. Include where the resident is being sent, the reason for transfer, the hospital destination if known, and the time or expected time of departure. Families often feel less anxious when they know exactly what happened and where to go. A critical rule is that family notification must not delay emergency care. If a resident is unresponsive or in severe respiratory distress, call 911 and begin interventions first. You can continue trying to reach the responsible party while the transfer process is underway. If no one answers, document every attempt, including phone numbers used, times called, and messages left according to policy. From a nursing standpoint, this communication should be factual and calm. Avoid speculation or promises. Say what you observed, what actions were taken, and what the next step is. Clear family notification supports trust, continuity, and informed involvement without interfering with urgent clinical priorities. The transfer packet is the written bridge between the nursing home and the hospital. If it is incomplete, the hospital team may not know the resident's baseline, medications, precautions, or treatment limitations. That can lead to delays, duplication of work, medication errors, or unsafe care. A standardized packet reduces those risks. At minimum, include the facility transfer form, the reason for transfer, current symptoms, recent vital signs, focused assessment findings, and the time symptoms began or the last known well time. Last known well is especially important in possible stroke because it may determine eligibility for treatment. Include a current medication administration record, allergies and reactions, and a list of medications or treatments given right before departure, such as oxygen, insulin, or pain medication. The packet should also communicate who this resident is clinically, diagnoses, significant history, recent labs and diagnostic results, provider orders, and recent nursing notes. Baseline mental and functional status is crucial because emergency staff do not know what is normal for this resident. Add mobility and transfer needs, aspiration or fall precautions, diet consistency, swallowing restrictions, wound care information, and infection or isolation status. Do not forget legal and practical items, code status documentation, advanced directives, emergency contact information, provider contacts, and insurance information. As a nurse, think of the packet as a snapshot that should let the hospital team safely continue care without guessing. Complete information supports a safer, faster, and more accurate handoff. A direct verbal handoff is one of the most important safety steps in transfer. Handing EMS a stack of papers is not enough. Verbal report highlights the urgent information and prevents key details from being overlooked. Start with who the resident is, name, date of birth, and normal baseline. For example, saying, usually alert to person and place, ambulates with a walker, gives immediate context for current decline. Then explain why the resident is being transferred, when symptoms began, and how the current condition differs from baseline. EMS and emergency department staff need to know whether this is a sudden change, a progressive decline, or a recurring issue. Include vital sign trends, current level of consciousness, and your focused assessment findings. Trends matter because a resident whose blood pressure is dropping or oxygen requirement is rising may be deteriorating rapidly. Always include code status, major diagnoses, and allergies. Share treatments already provided, such as oxygen, glucose check results, bleeding control, or medications administered before departure. If the resident has safety concerns like aspiration precautions, seizure risk, falls, or communication barriers, say them out loud. When possible, report directly to the receiving emergency department as well, especially if the resident has time-sensitive symptoms. Good handoff is like giving the next team a clinical headline, not making them read the whole textbook first. Nursing responsibility is to make the urgent issues unmistakably clear, so care continues without dangerous gaps. Preparing the resident for transport involves more than wheeling them to the door. Final checks protect identity, comfort, safety, and continuity of care. First, verify the resident using two identifiers, such as name and date of birth, and apply an identification band if required. Misidentification during a rushed transfer can lead to serious downstream errors. Next, maintain dignity. Residents are often frightened, uncomfortable, or confused during an acute event. Make sure they are appropriately dressed or covered, warm enough for transport, and not unnecessarily exposed. This is basic compassionate care, but it is also a professional responsibility. Secure all necessary equipment. If the resident requires oxygen, confirm it is connected correctly and available for transport. Make sure tubing, drains, or monitoring devices are not tangled or at risk of dislodgement. Reassess the resident immediately before departure when possible. A final set of vital signs can reveal deterioration and gives EMS the most current data. Be selective about belongings. Send essential items only, such as glasses, hearing aids, or dentures if needed for communication, orientation, or safety, and document them. Label personal items to reduce loss. Do not send controlled substances or other medications unless facility policy or the receiving facility specifically requires it. A helpful mental checklist is right resident, right documents, right equipment, right belongings, right condition for transport. These last-minute steps often seem small, but they reduce confusion, preserve dignity, and help the receiving team care for the resident safely from the moment of arrival. Thorough documentation tells the clinical story of the transfer from the first change in condition through the resident's departure. It supports continuity of care, legal protection, quality review, and communication among teams. Good charting is factual, time-based, and specific. Start with chronology. Record when the change was first observed, what the resident said or what staff noticed, and the exact sequence of assessment, interventions, calls, and departure. In urgent situations, precise times matter. For instance, in suspected stroke, the last known well time can directly affect treatment options in the hospital. Include focused assessment findings in all vital signs, not just the abnormal ones. Document interventions such as positioning, oxygen administration, blood glucose testing, bleeding control, CPR, or keeping the resident NPO. Then chart how the resident responded. Did oxygen improve saturation? Did mental status worsen? That trend information is valuable. Also document provider notification, the name of the provider, what was reported, orders received, and whether the provider was reached directly or by message. Record responsible party notification attempts, confirmation of code status, EMS arrival time, departure time, mode of transportation, destination hospital, documents and belongings sent, and the resident's condition at departure. Finally, identify who received handoff report, such as the paramedic's title or the receiving nurse if report was called to the ED. A useful rule for students is this. Chart so that someone reading your note later can reconstruct exactly what happened, what you did, and why the transfer occurred. After the resident leaves, the nurse's work is not finished. Internal communication and reporting help the facility manage risk, maintain regulatory compliance, and prepare for the resident's return. Notify the appropriate leader according to policy, which may include the charge nurse, nursing supervisor, director of nursing, administrator, medical director, or risk management. Early leadership awareness is especially important when the transfer involved deterioration, emergency response, family conflict, or a possible adverse event. Some transfers require an incident report. Common triggers include falls, injuries, medication errors, abuse allegations, elopement, or other reportable safety events. The incident report is for internal quality and risk review, not for the hospital, and generally not for the resident's medical record unless policy specifically states otherwise. Students should understand this distinction. The medical record contains factual resident care documentation, while the incident report supports internal event analysis. Post-departure follow-up may also be required. The facility may need to confirm that the resident arrived at the hospital, communicate updates to the responsible party, secure the resident's room and belongings, and hold medications only according to provider orders and policy. Later, when the resident returns, medication reconciliation and review of discharge instructions become critical to prevent discrepancies. The nursing implication is that safe transfer extends beyond the ambulance doors. Facilities learn from events through internal reporting, and residents benefit when staff close the loop with leadership, follow-up communication, and preparation for a safe return from the hospital. Let's bring the full process together. Before transfer, your priorities are to assess the resident immediately, compare current findings with baseline, begin emergency interventions, and confirm code status and advance directives. These steps answer the most important early questions. What is happening? How urgent is it? And what care is appropriate for this resident? Next comes transport planning. If the resident is having a life-threatening emergency, call 911 without delay. If the condition is stable and the provider orders hospital evaluation, arrange the appropriate non-emergency transport. At the same time, communication must be organized. Notify the provider using SBAR, contact the responsible party as soon as possible, and give a direct verbal handoff to EMS and, when possible, the emergency department. Do not forget the transfer essentials. Assemble a complete packet, verify the resident's identity, secure oxygen and needed equipment, and send only essential labeled belongings. Preserve dignity, warmth, and privacy throughout the process. Even in emergencies, respectful care matters. After departure, document thoroughly. Notify leadership according to policy, complete any needed incident reporting, and follow up with hospital arrival and later return planning. This includes preparing for medication reconciliation and new orders after hospitalization. If you remember only one rule, remember this one. In a life-threatening emergency, immediate bedside care and calling 911 come before paperwork and routine notifications. The safest nurse is the one who can prioritize action, communication, and documentation in the correct order while always keeping the resident at the center of care.